Here's the problem.
This is the very high risk issue. They think that transfusion is safe.
I go up to audit a transfusion administration and I'll walk in with the bag of red blood cells and the patient is like in the lounge chair, not on oxygen, watching TV. And I'm like, why are we must be correcting a number because obviously this patient isn't having problems.
We'll hear like, oh, I had a procedure. I gave my patient a platelet. They didn't bleed. That's awesome. Well, they probably wouldn't have bled whether you gave them the platelet or not. Just the fact that your patient didn't bleed does not mean that transfusion was necessary or effective.
But the University of Rochester makes a bold move.
We thought, you know what, let's try something different. Let's be renegades and try something different, and let's be brave.
How can we ensure that unsafe transfusion practices are discontinued?
You just need the guts to start with it. I don't need just to keep following arbitrary number that doesn't make any sense.
If you learn one thing from this episode,
Platelets are a liquid organ transplant, and they are not a benign therapy. Mic drop.
Your blood, your health, it's in your hands. Speak up loud, take your stand. A voice can shift the tides of care. Your blood, your health, be aware.
You got your mocha latte frate so that you can do this? Okay,
Everything. So I can tolerate that.
I am so excited to have Majed Refaai and Christine Cahill back. If you remember, we had an interview with them once prior when they actually worked together. They're no longer working together. But to reintroduce you, Dr. Refaai, he leads clinical service in transfusion medicine with a subspecialty in coagulation and thrombosis. Then Christine Cahill practiced for, I believe, 14 years. Is that correct? You were trained by Dr. Refaai, and you were his patient blood management program manager. Now you are in sunny Florida, and you are a patient program coordinator there for Mayo Clinic. I want to first congratulate Christine for being lead author on such an important paper and work that you did together. We're going to talk today about prophylactic half-dose platelet transfusion, the effect on thrombocytopenia, transfusion, bleeding occurrence in patients with hematologic disease. Very important work. Congratulations, Christine.
Thank you so much. I appreciate it. It's great to be here, and I'm so happy to talk about this project. Was a long time coming, and a lot of work and a lot of effort went into this paper. So I'm really thankful to have been a part of it.
What problem were you trying to solve by this study and by this protocol that you were able to help implement?
Well, I think most of us, all of us in the PBM world know that platelets are probably overused, not always understood, always in short supply. So many issues with platelets. So we really wanted to take a look at what we were doing. Basically, the transfusion guidelines are arbitrary, and a person that Dr. Refaai and I have worked with for a long time, Neil Blumberg, used to like to say that the platelet guidelines were made by a bunch of guys sitting around eating tuna fish. And as funny as that is, there's some truth to that. We thought, you know what, let's try something different. Let's be renegades and try something different, and let's be brave. There have been a couple of studies, small studies prior, looking at platelet dosages, which is also arbitrary. So we thought we could extend our inventory. We were going through some major inventory issues. We were tasked with trying to reduce our blood spend and because of budgetary issues. So we thought, you know what, maybe we can decrease the dose of platelets that we're giving and see if we can get the same effect. And we had done this before, not in a structured way, but like when we had inventory issues and we were forced to split those platelets to make them go further. We saw that, it really wasn't affecting platelets negatively. So we thought, let's do this formally. Let's do it the right way and take it to our clinical council and talk about it and actually study it and do this in a way that makes sense and it is in a scientific way.
Majed, can you educate us a little bit on, so there are four major components to blood. Today, we're focusing on platelets. Can you tell us why platelets are so important?
The platelet in general, it's very important in our normal process to stop bleeding, which we called it hemostasis. So normal hemostasis definitely required enough amount of platelets and functional platelets. That's why it's very important in bleeding patients, very important in patients going on surgery, important in just like any regular patients that may be at high risk for bleeding, for like medical procedures or surgery, as I said, in general. Now, there's definitely a lot of other rules for platelet. I'm not going to mention it here. It's going to take the entire hour. But the most important part of the platelets in some patients are the one with some bone marrow malignancies or some bone marrow procedures been done, or after stem cell, for example, or in patients with chemotherapy because of some hematological malignancies. What happened is their bone marrow stopped producing these platelets. And until the stem cell or the bone marrow transplant kick in and start making new platelets, they may become platelet dependent. We call them platelet dependent patients, which means that we have to keep them at certain level most of the time, especially for those patients who could be at high risk for bleeding. These patients are in general on chemotherapy, on a lot of antibiotics sometimes. Even the platelet we transfuse them, they do not maintain them for a long time. So they become really very platelet dependent. And in this case, platelet transfusion is very important in these patients in general.
Platelet transfusions are incredibly common. Why challenge something that's so ingrained and we use all the time?
Why not? I mean, we need to challenge something. If you just go back to any blood transfusion practices, regardless of the product, just don't look at the product. You'll find that these policies were created arbitrarily. These policies were made just like the same things that Dr. Blumberg mentioned, like sitting eating tuna or whatever, and then decide, okay, let's choose hemoglobin of 10. Let's choose platelet count of 50. There's no significant studies were done to establish this. Everybody took these numbers and move on with these numbers. And they are hesitant to change. They don't want to change. They've been doing this for years. I'm going to continue with this. It's very hard to challenge. But when you get forced, when you get to the point that you have no any other choice, like we found this during COVID era, we get to the point that the blood donor center calling us says there's no shipment today. We don't have blood to give it to you. How can we do it when we have a reason for it and then we don't do it? We actually abuse it when we have plenty of products sitting on our shelves. The main problem is two problems actually. One of them is doctors in general. They don't want to change their practice. Period. Don't even talk to me about it. And number two, and this is the very high risk issue, is they think that transfusion is safe. Transfusion is, I can tell you, transfusion 100% is not safe. Yes, transfusion needed for patients who don't have any other option. We talk about those cancer patients who has no bone marrow to make blood component, no platelets, no red blood cells. It's important in somebody who came from trauma and is bleeding a few liters every minute. With these two issues, that I don't want to change my policy and blood transfusion is safe. We just have to keep in mind that it's not 100% safe.
We'll hear like, oh, I had a procedure. I gave my patient a platelet. They didn't bleed. That's awesome. Well, they probably wouldn't have bled whether you gave them the platelet or not. And we do have, thankfully, some evidence and research from the bloodless community that has shown that a lot of these platelet transfusions are probably unnecessary, particularly in procedures with the new platelet guideline. Just the fact that your patient didn't bleed does not mean that transfusion was necessary or effective.
It seems like more and more in the literature, and I felt like your article as well pointed out that unless the patient is bleeding, prophylactic or a just in case transfusion in both red cells and in platelets is probably a bad idea. Would you agree with that?
Yeah.
Of course, of course. If it's not needed, why give it? Don't look at your patients as just a lab results. Look at your patients clinically. Does he really need that? I mean, I have a lot of examples. I have some doctors who are champions of patient blood management. They inform their staff even when they are not at the hospital. Don't transfuse my patients until it's really needed, and if you are not sure, contact me. I have some PAs calling their doctors in the middle of the night, like 2 o'clock, 3 o'clock in the morning, to ask him if should I give him a red blood cell. His hemoglobin is 6. He answered them, is the patient is sitting, talking to you? Is he gasping for air? No. Is he talking, continuing a sentence? Yeah. Yes. Don't transfuse. Just look at each patient. If this patient's coming from under a bus for a trauma, and his hemoglobin is 6 and he's bleeding and cannot maintain his oxygenation, yes, I would transfuse him. But somebody's sitting on the floor, sitting in his bed, waiting for his procedure, why give him transfusion if not needed? Look at the clinical aspect of your patients. Don't look at your labs.
I see it all the time. I go up to audit a transfusion administration and I'll walk in with the bag of red blood cells and the patient is like in the lounge chair, not on oxygen, watching TV. And I'm like, we must be correcting a number because obviously this patient isn't having problems.
I'm very sure he does not need transfusion to flip the remote control.
But with platelets too, you have to be concerned about like refractoriness. So eventually you keep giving these platelets to people just in case so that they don't bleed. All of a sudden now those platelets don't work anymore. Now what are you going to do? And on top of that, those platelets cost 2 to 3 times as much and they're difficult to find. It's difficult to get donors. Sometimes we have to bring donors in specifically for certain patients. That's not the best use of that donor's time either. I mean, thankfully, there's a lot of like altruistic people in the world, but without them, it's very difficult. Sometimes we have patients where we're like, we can't find platelets for you. I'm sorry. And then what?
I see this in chart review where we dosed platelets or we gave platelets and it nudged the number a little bit and then 12 hours later, it's back down. So refractoriness. Dr. Refaai, can you tell us what that is and what causes it?
We see this in patients who are platelet transfusion dependent patients, so we transfuse them very often. And what happened is exposure to all of these antigens on these platelet membrane. Platelet has tons of antigens. Your immune system is going to develop antibodies against them. And to get to the point that even when we get to the point that we're going to get them a specific HLA type match platelet, we get to the point sometimes that their PRA, which is the percentage of the antibodies for these platelets in general, for these platelets antigens, could reach up to 100%, which means like I cannot even find you a platelet. Any platelet I'm going to give it to you, your immune system is going to destroy it. A lot of physicians, they don't pay attention to this. They just pay attention, my patient's platelet count today is 10. I want it to be 15. Give him a unit. 15, I want it to be 20. Give him a unit. Why? I mean, he's sitting, doing nothing, waiting for his procedure, waiting for his chemotherapy. He's not at high risk of bleeding. Don't touch him. Don't touch him. Don't pay attention to the number. Okay? Don't touch him. By repeating this, his immune system is going to develop antibodies against these not my antigens platelet. And that will get him to the refractoriness.
I saw on social media when the paper came out, people were really responding very well to this paper because it's such a bold move. I can only imagine that if we tried this in my hospital organization, we would get so much pushback from many service lines, but especially where you looked at it, which was the cancer population. So did you have a lot of pushback?
Well, I'll talk a little bit and then let Christine also explain her point of view because she was here at that time and we started this program together. The entire thing started around the COVID era, where as I told you, like sometimes we are the only trauma level 1 center in the entire Rochester area, serving about 200 to 250,000 population. If you add also the surrounding, we could reach close to three quarter of a million. For a trauma level 1 center to have 5 platelet doses on your shelf for the entire day, this is not comfortable. Not comfortable. Most of the the elective procedures done during the day and stuff. So during the day, maybe by the time of the evening hours, we have 2 platelets on our shelf. And this is not good for the night shift because there's no donor center to bring us any shipment. We already got the shipment for the day. Our shipment used to be 15 to 20 platelets, dropped down to 5 to 6, 7 sometimes, not even reaching up to 10. With all of this and all of the trauma level 1 center we have here, all the bleeding patients come here. The minute by being at this risk, and then somebody sitting in the floor, as we just say, watching his TV, and his doctor ordered platelet for him, his platelet count is 15, he wanted to be 20, or 10 wanted to be 15, whatever. I'm not going to give you a full unit of platelet and risk my trauma patients or risk my OR patients who is bleeding on a table and tell the surgeon I don't have platelets to fix the platelet count of your patient sitting flipping the remote control in his room, So that's kind of like where we started. And we get to the point that, okay, we have these patients, they only need to increase them a little bit. Why give them a full unit? We have all the measures to sterilely make these half doses. Why don't we, instead of having 5, we could consider us having 10 on our shelves instead of 5 doses? We started doing this, and we were lucky enough because we were already doing this for pediatrics. We have a standing by itself children's hospital that we send them with syringes. We already have a sterile system sitting there that we could use. That's how we started splitting these. We decided to split these because we are running out of platelet. We don't have enough inventory of platelets. So that's how we did it on our own first. Then when we saw it's working, I said, wait a second, why don't we just make this as policy? Really very quick. Me and Christine, we created the protocol, we created the policy, we sent it to Dr. Blumberg. At that time was Dr. Neil Blumberg, was our blood bank medical director at that time. We wanted him to approach the clinical council committee, which is all the C-suite names are there, all the chairmen of different departments, they meet on a monthly basis. We said, why don't you just take this and to them and try to convince them that we have no any other options. To be honest with you, I was shocked. It was approved from the first meeting. We start using it for, as we said, any patients except bleeding patients. Bleeding patients will issue a unit right away. We start doing this for everyone. We were lucky. I mean, sometimes we leave the evening shift with 10 doses of platelet on the shelves, like 5 units, but could be 10 if needed. But at least they feel much more comfortable now by the night shift.
So you told the whole story already.
And I mean, I could not stop.
I know you're so
Right.
excited. Well, this is the one thing though. He says we got lucky. I don't think it was luck. I think number one, at the U of R, the clinicians trust the transfusion medicine physicians because you guys are very strong. You have plenty of research to back up the things that you're saying. Your own research. You have a very good reputation. So at U of R, I think the clinicians acknowledge that this transfusion medicine service is there to help. It's a consult service. It's not a repository.
Yes.
It's not a place where we keep blood. A blood bank is that, but it's not just that. So I think that was definitely part of it. The other piece of it was, when we told them, well, we're kind of already doing this. So now we're letting you in on the secret that we already were doing this.
Right.
So could you please just say yes? That it wasn't exactly those words, but that was the gist of it.
Yeah.
Also, there was a little bit of deal making too. So we didn't have the platelets for the patients that were outpatient. That was a big concern because they were like, oh, we don't want to have these people coming back multiple times. We also assured them that if we gave them a half dose platelet and something happened, your platelet needed more platelets, we would send them the other half of that platelet. They recognize the expertise in the room. Dr. Blumberg has been in the blood bank for many, many years. Dr. Refaai has a great reputation. I think a lot of times transfusion medicine physicians don't want to leave the blood bank, and ours did. And so once people see, oh, wow, these guys actually know what they're talking about, or these ladies actually know what they're talking about. Sometimes there's ladies too. That makes a much bigger impact in your clinical service. If you blood bankers stay behind the doors and never leave, no one knows you're there. So I think to other, other hospitals, it's very important to get out there, because I know you guys are smart, intelligent people that have a lot to say. It's hard to go out in front and talk to people, particularly when it's not something that you're comfortable with. But I think it's really important that you show people that you're a consult service. You're not just it's not a repository. It's not a place just to store things. You're actually doing science.
I think you brought up a really good point, Christine, because I don't believe in all institutions that relationship is that good between the blood bank and the clinicians or the executives. It's really, really important that the transfusion medicine service is seen as the authority in transfusion medicine when they're recommending something to value what they are bringing to the table. Christine, I'm going to ask you then, how did you operationalize this?
Well, so basically, as Dr. Refaai said, we already had a process for splitting platelets because of our children's hospital. So we decided, okay, how can we choose the right patients? First of all, we wanted to make sure that when we were looking retrospectively, we wanted to be able to match the patients appropriately, because obviously that's a limitation. We also had some issues with people that were on WASH protocol, so we needed to make sure that we could exclude those patients easily. We wanted to look at prophylactic platelets. We didn't want to look at platelets for procedures. We didn't want to look at platelets for patients that are bleeding. We wanted to make sure that those patients were not part of the study, because those are people that would probably need a full dose of platelets, even under our protocol. So we picked a small group of patients, which were cancer patients, all different types, bone marrow, CLL. We had multiple different types of cancer and leukemic patients. But these were all patients that had lower platelet counts that were receiving them for prophylactic. So patients mostly with a platelet count of 10,000 or less. That's kind of how we found this group of patients. Once we found that there was really no difference in bleeding, no difference in complications, then we were able to take that research to our clinical council and show them, we would like to do this for everybody. Obviously, like we've said before multiple times, there's exceptions to the rule. If you need more platelets, we can get you more. But in every other aspect of medicine, like other therapies, we give the smallest possible effective dose. So basically what we were saying to them was, we're looking to do the same thing. We're not looking to skimp. We're not looking to save money. We're not looking to cheat you. We're looking to give the smallest effective dose to your patient to minimize complications. And they were like, okay. So that was basically the process. We did assure them that we would come back periodically to tell them like how things were going, if there were any signals that we saw that maybe potentially would show some issues or danger. We never saw any danger signals. We were able to report to them, no change. Everything is looking great. The process was working smoothly. No major delays. We didn't have surgical delays. We didn't have any like major issues to report. At that point, it was kind of made into a official protocol.
Majed, this was not a clinical trial. This was real world implementation. Why did you choose to go that route?
It's not easy to do a randomized control trials in this setting. In the same hospital, sometimes you could have multiple transfusion policies. So imagine different hospitals, different part of the country, or different setting of different hospitals. So it's not easy to do a randomized control trials in this. Plus also, to be honest with you, the real world data is much more important than the randomized trials. Because when you look, especially when you go back and look retrospectively to see how did we do on these patients, did we harm these patients? We just collecting the data, all the data is there. So we just collect the data and look at it. When you do randomized control trials, you start from the beginning with excluding patients. This patient has heart problems. This patient has lung symptoms. This patient has anemia. You basically trying to, you are biased to start with, When you don't have this, then that's number one. Number two, you have also to push the other hospitals to use the same policy, because you can't do a randomized control trials from different policies. Like, for example, I'm just going to tell you again another things that Dr. Blumberg said. He said, like, we may be one of the only hospital in this world or on this planet that we wash as much as platelet as needed. We also give ABO specific, identical, if possible. Like, once we identify, if we don't have that type, we wash to remove the antibodies from this plasma. We use local reduced. We use pathogen treated platelets. If all of these are not available for all the hospitals, you're going to be having a lot of variations between different hospitals. Plus, also, how you're going to convince everyone in that the doctor of any hospital, that's what we're going to do. We're going to give you half a dose instead of full dose. It wasn't an easy thing to do at our center, so now you want to implement it at different centers. So randomized control trials in this setting is a little bit hard. That's why looking at the real world data we found it very straightforward, and it's telling you exactly what's out there. It's telling you, like, what have you been done? Let's look at it. We didn't know. I mean, when Christine started collecting the data, we didn't know what we're doing. Like, to be honest with you, I thought, like, maybe, although we are giving half a dose, I told Christine, let's look if we are giving more platelet than usual. My patient's taking half dose, I'm going to order 2 for him. One now and one when you go home after the evening shift, just like, because no one will tell me something about it or about my second order. On our data, we did not find that. Okay. We thought that maybe when we give them less platelet, they may bleed more. We didn't find any difference in the bleeding. Maybe they transfusing more red blood cells. We didn't find either. So was looking at all of this real data, like the data just generated because of this new policy. We were shocked. I mean, I was like, man, we literally did not give double of the amount of the platelets. We did not cause any patients to bleed. So that was a very good data.
Yeah. Also on the RCT, we really didn't have a lot of time, because one of the issues, obviously, we wanted to do what's best for the patient. But one of the big issues that we kind of already alluded to was the inventory. Post-COVID, like, nobody knew what was going to happen. Everyone was having problems with platelets. We needed to do something creative just in case, because who knows what's going to happen? What's the next virus that's going to come? If COVID was a bleeding virus, that would have been,
We'll be done.
it would have been the end of the world. So there's also time, and we really wanted to start doing something, as opposed to, like, going through the process of RCT and the different phases and things like that, because that would have taken five years probably or more.
Well, retrospective design always raises concerns. What is the biggest limitation, or what are things that critics might point out?
The matching was the biggest challenge, and that's usually what people kind of complain about. But because we use such a kind of narrow inclusion-exclusion criteria with age and with diagnosis, I think we were pretty successful in finding a good matched cohort. If we tried to do this with study the entire hospital, it would have been very difficult, because it would have been so many different types of patients, so many different scenarios. All of our patients had pretty close to the same pre-transfusion platelet counts. They were in the hospital. They were all inpatient. They had similar diagnoses. They were there for the same reasons. That's usually where, and we really did our best not to cherry pick, and we really didn't exclude many patients in that. We really just took what we had, and, like, really just, these are our patients. This is our patient population.
Let's get into the results. I know Dr. Refaai already kind of alluded to the results, but what surprised you the most?
Christine, can you take this? I just have to respond to this call. I'm sorry.
Sure. Absolutely. We were pretty confident that we were doing the right thing, but we didn't really know 100%. We were concerned that, okay, by having the dose, they were just going to give more doses. So we were going to be in the same place, just giving more frequent transfusion reactions as opposed to larger. But what we did find was that they were not ordering additional half units. So that was really very surprising, and also it really gave us a lot of confidence what we were doing was the right thing.
How about you? What were you most impressed with the results, Dr. Refaai?
In the control group, we did see jump in the platelet count right after the transfusion of the full unit. We saw a little bit of jump in the half dose, but when you go to 12 to 16 hours and 24 hours after the transfusion, they were identical. There was no significantly different. So yes, I'm making the physician feel happy after the platelet transfusion. That's, oh, my platelet count, my patients went from 10 to 35 or 40. Oh, I'm so happy. But 24 hours later, he's back to 10. You know, same was the other one. It did go to up to 20 or 25 and came back to 10 within 24 hours. So that was really like a surprise for me. We did not cause more platelet. Like, I don't want this physician to transfuse within 12 hours another half of the platelet, although they know that we are giving half. It's not secret, as we said. We did not see this. So that was amazing for me.
So you cut the platelet volume roughly in half, but their outcomes did not really change at all. Can you explain why the outcomes were so similar?
The dosage, like we said, it's arbitrary. A lot of these patients, even some of the patients that we gave half doses to, I mean, I can't say for certain, but there's probably a certain percentage of those patients that needed 0 platelets. This is our way of changing the needle a little bit and start thinking about what are we doing and why are we doing it? Are we just doing it to fix a number? Or are we really looking at the patient and what their needs are? One of the things that Dr. Blumberg used to pound in my head and in others too is platelets are prothrombotic and pro-inflammatory. Thrombosis and inflammation are probably 2 of the scariest things in a hospitalized patient, because we know that usually leads to all sorts of bad outcomes. We do a lot of things to avoid that, yet we give a substance that is known to cause both of those things. So we really need to start, considering what are we doing and why are we doing it, and what is the true benefit of what we're doing with these dosages.
Prophylactic transfusions of platelets, physicians are just concerned that if I don't, they'll bleed. That's the concern. By giving less, have you seen that there is any increased bleeding occurring?
Not at all. Not at all. It was one of the secondary points that we look at in this data. We sent all the data to a statistician to look at it, and it came back with like very significant outcome that we did not see any increase in bleeding, which was another astounding findings. It's really great that we did not cause bleeding, which take us back again to Christine's questions. Do they really need that platelet to start with? Not even prophylactic. Put the prophylactic on the side, but do they really need that platelet to start with?
Yeah. We know that we are not really compromising safety by giving less. Are we compromising patient safety by giving more?
Of course. I mean, Christine did touch base on this just a moment ago. As we said, platelets are pro-inflammatory, prothrombotic product. Platelets in general, during the storage, they generate a lot of what we call storage lesions, and they shed a lot of microparticles. All of these microparticles are prothrombotic on their own, So yes, we are increasing risk when we give it to the patients, increasing risk of inflammation, increasing risk of thrombosis, and increasing the risk of what we call immunomodulation, which is a term, transfusion-related immunomodulation disorders, that will affect his immune system, even fighting his own disorder or his own disease, where he need the most of his immune system, he needed it during that time, or the patients needed it during that time. we are modifying this and we are changing this in his immune system. Of course, all of these, if we can avoid them. Plus, I haven't added or haven't touched base on the transfusion reactions. That's very well known transfusion reactions that we know of. There's a lot of transfusion reactions we don't touch base on because they always just related it to the patient's disorder. Well, where it's actually basically could be coming from that bag you transfused for no reason or just to fix a lab results.
We need to also be good stewards of this very rare resource, because you're giving, okay, say you're giving a transfusion to a person that probably doesn't need it, and someone comes in. I mean, we've had traumas that required 30 shipments of MTP. And okay, now we're running out of platelets. What are we going to do? So we really need to some extent, obviously, we need to make good decisions for each patient. Each patient event is its own event. But we do need to think about the inventory as a whole and triage those platelets so that the people that need them the most are first in line to get them.
Half dose platelets is a standard of care at the University of Rochester. What would really need to take place for that to become a standard of care everywhere?
Dr. Blumberg needs to go work in every blood bank, but I think he's retiring.
Right?
So I don't know. Yeah. We're going to need some clones of Dr. Refaai and Dr. Blumberg to go around the country.
We need a lot of clones. Yeah, I mean, it's not easy, but it's not impossible. I mean, if you really find the measures to do so on the blood bank level, and then find the good representative of the blood bank and coagulation experience, you need a very good blood bank, a medical director that can reach out to the big names and big users of the blood products in each hospital and discuss with them the issue with inventory, number one, reactions, and unneeded transfusions, number two. It would be easy to generate such policies in any hospital. You just need the guts to start with it. I don't need just to keep following arbitrary number that doesn't make any sense. I know some centers that they transfuse in double. They don't even transfuse one, to start with.
Yeah.
You know from SABM how long we've been fighting this habits, and we were able to change it in a lot of hospitals. Started with few hospitals, and now it's across the entire country, I think. Maybe still some centers they do it, but there's like every single order of red blood cells, for example, it used to be in double. There's no one. One's not going to be benefit, so always double. And we were able to change this. So it will take time. If we really push for it, and more data coming from different hospitals, more patients' outcome get published, and case reports maybe, it will eventually could be implemented nationwide. Yeah. We did this with red blood cells. It's just a matter of time.
You also need a strong patient blood management program and a strong nurse manager, coordinator. Yeah, so it can be a few different people that are needed in this equation. But you really need someone to champion this. It's hard. It is hard. It took a lot of work. I would love to see this replicated. Don't take our word for it. Like, do it in your own hospital. Try it out. Take a small portion of your population that you feel comfortable with, get a champion, and try it and see what happens. Maybe your experience will be exactly the same as ours. I'm pretty confident it will. But yeah, I'd love to see more studies. There's been a few before us, so we weren't the first. We were the first in this population. But yeah, I'd love to see more. So bring it on.
I love the great work that you're doing and the disruptive nature. I think you make a really good point that a good patient blood management program is important. We are seeing more and more organizations implement those positions inside of hospitals. I'm also very excited to be working with you both, because I know that's a passion of all of us, to be implementing patient blood management programs so that we can see results like this. In one sentence, what's the biggest misconception about platelet transfusion that this study challenges?
In one sentence, just don't target the fixing of lab results. Make your focus your patient. Don't worry about a little bit of abnormal lab results if clinically is not indicated. Think about transfusion as an organ transplant. We all know that transfusion, blood is an organ. And you basically, every time you're doing transfusion, you are doing an organ transplant to your patient. So think about this. I mean, think about doing this to your relatives. Don't get into that level of need to correct just lab results. If clinically there's no indication to correct, there's no risk at this patient to correct these results, I would not consider correcting them, and I would not consider transfusion.
I have one sentence. I have one. Platelets are a liquid organ transplant, and they are not a benign therapy.
Yep.
Mic drop.
Done. Done. Period. That's a good patients with management coordinator.
You taught me well. Well, if I sent him an email that was too long, I knew he wouldn't read it, so I had to learn how to condense my words.
Of course. Just one line.
And not even in the body, in the subject line. That's it. No body.
As always, it's a barrel of laughs with you guys, and it's such a pleasure. Thank you for letting me talk to you about this study, and I will link it in the description.
Thank you very much. Thanks for having us.
Thank you.
If you enjoy the conversations we're having, don't forget to comment, like, share, and subscribe. It helps bring awareness to the importance of understanding decisions when it comes to your blood.